Dear colleagues, this talk is about the value of robotic ablation of atrial fibrillation. The work was done in Czech Republic ICM Institute with Professor Josef Kotzner. This analysis assesses the effect of robotic techniques on the results of atrial fibrillation ablation. The goals of atrial fibrillation ablation procedures are to prevent atrial fibrillation by either eliminating the trigger that initiates the fibrillation or by alternating the arrhythmogenic substrate ablation of paroxysmal atrial fibrillation. The most commonly employed ablation strategy today, which involves the electrical isolation of the pulmonary veins by creation of circumferential lesions around the right and left pulmonary vein ostia, probably impacts both the trigger and the substrate. There are triggers, we ablate it to eliminate it. Catheter-based ablation of atrial fibrillation places significant demands on skill and experience of the electrophysiologist. The objectives of developing new techniques to facilitate these procedures include precise and stable catheter navigation, reduced radiation exposure, shorter procedures, and cost effectiveness. While new technologies generally increase the cost of a procedure when they are introduced, the costs may justify the improved outcome. The Hansen Sensi apparatus from Mountain View, California, integrates robotic technology with computed movement, merge between the CT and the robot. The key aspect is an electromechanical manipulation that is designed to provide physicians with precise catheter control and 3D navigation within the heart from the workstation, while the operator is away from the operating table. The aim of this work was to evaluate the feasibility of catheter ablation in patients with paroxysmal atrial fibrillation using different technologies and its effect on terms of procedure efficacy and success rate. This is the apparatus. The operator is outside the catheter room, manipulating it in front of him, the screen. We studied 150 patients, 86 male and 64 females, having a mean age of 51, who suffered from systematic drug-refractory paroxysmal atrial fibrillation. Work was done in ICM Institute, Prague, Czech Republic, from 2008 to 2010 as part of the doctoral degree of Dr. Amr Kamal. Patients were subjected to the following: full history taking, clinical examination, baseline ECG, routine laboratory work, X-ray chest, transesophageal echo, cardiac multi-slice CT, and intracardiac echo. Three-dimensional electroanatomic mapping, the Insight Navix system, the CARTO mapping system, and radiofrequency catheter ablation, robotic catheter ablation, manual catheter ablation, post-procedural management and follow-up of patients were followed up regularly at outpatient arrhythmia clinic 3 to 6 and 9 and 12 months, as well as at any time for any possible attacks of arrhythmic recurrence. Patients were followed up as regards clinical symptoms, standard ECG, in-hospital telemetry, 7-day Holter monitoring, outpatient mobile telemetry with loop recording. So remember how many apparatuses we used: the CARTO system, the robotic system, the Navix system. We divided the patients into 3 groups. Group C, CARTO group, 40 patients with paroxysmal atrial fibrillation who underwent ablation using CARTO technology. Group N, 40 patients with paroxysmal atrial fibrillation using new apparatus is called Navix. And Group R, 70 patients with paroxysmal atrial fibrillation who underwent ablation using Navix technology and the use of robotic catheter ablation. We integrated two systems together, the CT computed tomography with the CARTO mapping system. This is merge between two units, two systems. CT image fusion or merge with 3D CARTO map was done to most of the patients. The CT image was imported into the electroanatomic map system using special software. Integration of CT image into Insight and Navix also was done. Ablation procedures. Ablation was done in all patients using the open irrigation ablation catheter in the power controlled mode, either manually or after mounting on artisan catheter for remote robotic catheter ablation. The irrigation catheter, it pushes fluid at the tip so to diminish the temperature of the tip. This is the CT with CARTO. CT showing the vessels and the CARTO showing the electric current direction. The end point of the ablation was the discontinuation between the pulmonary vein and the left atrium and the non-inducibility of atrial fibrillation. Disconnection means the removal of the atrial fibrillation artifacts. Peri-procedural anticoagulation during catheter ablation. After the procedure, heparin infusion is discontinued. Warfarin therapy. Of course, during ablation, we are infusing heparin to prevent thrombi on the catheter and cerebral emboli. Warfarin, heparin is discontinued after the catheter. Warfarin therapy is restarted in all patients, either the same evening of the ablation procedure or next morning. In the initial period, low molecular weight heparin enoxaparin subcutaneous is given as bridging therapy by starting 3 to 4 hours after the ablation, or alternatively, heparin is administered intravenously until the day after the procedure, starting about 3 hours after the sheath removal at a rate 1,000 units per hour. Thereafter, low molecular weight is administered until the INR is 2. Once the therapeutic INR is achieved, low molecular weight is discontinued. Heparin and warfarin is continued for at least 3 months. So even the patient is in sinus rhythm, we continue warfarin for 3 months. For most patients with SHAD score more than 2, to continue long-term warfarin treatment with target INR 2 to 3 is usually needed. These are the catheters. This is the intracardiac echocardiographic catheter. This is the electrode, the probe of intracardiac electrocardiography. And this is the ablation catheter, and this is the mapping catheter. Cardiac multi-slice CT image integration to the 3D electroanatomic left atrial map was used in 106 patients. All of them received intracardiac echo-guided imaging during the ablation procedure. 40 patients underwent manual radiofrequency ablation. 40 patients received ablation by Navix. 70 patients by robotic ablation. Pulmonary vein isolation was done into all patients using either pulmonary vein antral isolation or circumferential pulmonary vein in 22%. Circumferential pulmonary vein ablation was usually associated with posterior wall ablation. All patients were followed at 3, 6, 9, 12 months. This is the ablation of the antrum of the pulmonary veins, left and right side. Total fluoroscopy time, manual group, 19 minutes versus 6.9 minutes in the robotic group. 34 patients developed early recurrence of atrial fibrillation after an initial blanking period. We had 16 patients with treatment failure at short-term follow-up. This number increased to 18 patients at mid-term follow-up and further small increase to 20 patients at long-term follow-up. So the recurrence maximum was 20%. So the success is 80%. This is very good. Complications, none in 92%, air embolism 0, cardiac tamponade 0, trivial pericardial effusion 1, groin hematoma 5, pulmonary vein stenosis more than 50% 0, no difference in complications between robotic and manual groups. This is the comparison between the 3 groups. total number of ablation points in the robotic group was 70, in the manual group 80. Total ablation time here was 1,300 seconds. Here 2,000. Total fluoroscopy time here 19.9 seconds, here 6.9 seconds. Total fluoroscopy dose here 2,200 rad, here 550 rad. Comparison between manual and robotic groups as regards complications, no difference. This is the ablation of atrial fibrillation reverted to sinus rhythm. The AF artifacts are removed by ablation, and the patient reverted to sinus rhythm. Long term, the primary efficacy endpoint was complete success with no recurrence from 9 months up to 12 months after ablation procedure without use of antiarrhythmic drugs in 77% of the manual group and 85% of the robotic group. Long-term comprehensive success was also calculated from 9 months and up to 12 months after ablation procedures as the sum of primary and secondary efficacy points, reflecting reduction of atrial fibrillation burden. It was 82% in the manual group, 91% in the robotic group. 91% in the robotic is very successful and very good result. These are the results in group C, group R, the robotic. There is significant, as regards complications, no difference. Here, as regards complications, no difference. Primary efficacy, secondary efficacy, comprehensive success and failure. In all the groups, the robotic was better. Conclusions: the ideal ablation strategy for atrial fibrillation uses the least amount of ablation to achieve the highest success. Comparison of the manual group and the robotic was associated with greater number of ablation points and longer total ablation time in the manual group. Robotic navigation system could perform ablation procedures in a substantially equivalent manner to conventional manual controlled catheters. However, the remote robotic navigation system would be able to overcome the limitations of manual control by combining the ease of navigation with readily available wide navigation field. In addition, it will reduce the physician's radiation exposure during longer procedures and catheter ablation. Remote robotic catheter navigation system can add precious catheter control, stability, and maneuverability to electrophysiology mapping and ablation procedures. These features, coupled with the added safety and intelligence and the potential lesion and the map optimization using catheter tissue interface pressure, make the robotic catheter control an effective option for modern EP lab. Robotic ablation was associated with significant lower fluoroscopy exposure as well as significantly shorter overall procedure time. Robotic ablation is as effective and safe as manual ablation with very low procedural and post-procedural complications. Thank you. The lecture will be put on my YouTube channel by my name, Samir Rafla, and I hope if you see it and like it, subscribe to the channel and put like. These are the references. Thank you.